Jennie will Great. Jennie will then do the second half, and then I'll finish on the last slide, and then we'll open it up for questions. So please feel free to, save your questions till the end, and we'll do our best to answer them. Okay, so let me see. Okay, so we're going to talk about 4 research studies, all linked to one theme of improving the management of children's pain in hospital. And we have 2 leaflets and 3 animations to share. Now, the animations are just very short, little 3-minute videos. Please feel happy to have questions at the end. So a little bit about the context before we share the 4 studies. This is very old, but still very relevant. So when I was doing my doctorate in education in 1999, so this is 25 years ago, I interviewed matched pairs of parents and nurses. And I asked 20 nurses, are parents involved in their child's care? And the nurses across the piece said, they're always there. And when I asked the nurses if a child was in pain, would the parent let you know? They said, absolutely. So then I, with the matched pairs, went and found the parent of the child who each nurse was looking after and said to the parents, were you involved in your child's care? And they said, I heard what was being discussed. And then 14 out of the 20 children had moderate to severe pain. And what each time when a parent would say to me, my child had a lot of pain, I'd say, did you let the nurse know? And they said, I didn't want to bother her. So hold on to that thought. So the first study I'm going to talk to you about this evening was a travel scholarship, which I got from the very luckily from the Florence Nightingale Foundation. This was back in 2012. And I'd got to the point where I had been looking at pain studies and studying this whole field, and everything was negative. Pain isn't done very well, children are left in pain, parents aren't involved, blah, 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 all quite negative. And I thought, I know that there's really good practice in pain management. So I'm going to turn it on its head and go to 3 areas of excellence and pick the brains of these practitioners and say, what are you doing well? So I went to, I spent a week in Liverpool's Alderhay, and it's one of the centres of excellence in relation to children's nursing across Europe. I went to Stockholm because I wanted to have a look at a different progressive health system. And then I went to Australia to spend a week in Sydney because I wanted a comparison internationally, but I knew that America wouldn't give me that because of the different healthcare systems there. So when I spoke to all of these 28 practitioners and asked them about what's good, what innovations have you come across lately, I came up with 5 themes. And what these practitioners were telling me in total were, you need, for good pain management, you need distributed pain management with vision. So everybody needs to be working together and know what they're aiming for. Effective pain management is then delivered with less stress and delivered with confidence. And there's an individual approach to child and parent. And all of these other elements amounts to raising the parents' expectations of effective pain management. And different practitioners were very clear that if you raised parents' expectations, they in turn, by the way they worked with nurses, managed to increase or improve the management of their children's pain. So what do we do with that information? We thought, right, we need now to check this out. Are these 5 elements any good? Yeah, they're reliable. So we did another study, and this was funded by Wellchild, and we interviewed 43 practitioners across the UK and Ireland. So this is from the special interest group called the Pediatric Pain Travelling Club, which Jennie is, would you say your chair, Jennie, or network convener? So we went far and wide, went to Dublin and everything. So we had focus groups with 17 nurses, 6 band 5 nurses, and 11 advanced nurse practitioners, and face-to-face and remote interviews with another 26 pain specialists, 10 were consultants, and 16 were clinical nurse specialists. So in total, we managed to speak to 17 pain teams. And the key question was, what's the practicalities of the 5 elements? Would they work? What did they think? So In relation to the first point, which was about distributed pain management with vision, we were told pain is everyone's business, and that was so the PN is a pain nurse, C is a consultant, and ANP in these quotes are advanced nurse practitioner. So they said it certainly would be the ideal, as it would generate a stronger feeling of buy-in, giving people a voice and letting them come back to you, and ownership of creating change. One pain nurse said, I think we have ownership, you feel more empowered, and then the patients get better care. And it was noted that the ANPs, they actually really did stand out in this study because they felt they were part of distributed leadership of effective pain management. Moving on to the second element, most participants talked of the importance of keeping children and their families informed, as this could help mitigate stress related to pain management. And one of the consultants said, discussing with families ahead of a painful episode and letting them know what to expect, the people available, people assessing the pain management, and make adjustments if required. And this was, so what they were basically saying was, when parents and children have information about pain management, it is less stressful. So no surprises there. And then the third element, delivered with confidence. The key factor included the experience, the education, and device training as well. And noting that you can't be confident with your pain delivery unless you've had the training to know that what you're doing is right. And across the board, practitioners agreed confidence was actually really quite an important aspect of good pain management. They said suboptimal prescription and dosage was linked to a lack of confidence, with participating participants noting that there's a tendency to underdose, and as I say, it's a confidence issue. So the fourth angle was individual care approach to child and parent, and it was noted that parents lose confidence if their child is left in pain. Most practitioners agreed that an individual approach was an important aspect of managing children's pain, acknowledging that it should be paramount in all aspects of care, but certainly within pain management. And this meant that even when working with a protocol, tailoring it to that child or family. So across the board, this was an angle of effective pain management that was being agreed with. And then the last one was raising parents' expectations of effective pain management. And parents' expectations, we were told by a consultant, may not be voiced, may not be asked. But most thought that sharing realistic expectations was helpful, explaining that the use of a pain pathway helps with parents' expectations of how their child's pain will be managed. And parents' understanding of pain should be checked, not assumed. And many, many, many of these aspects come out at our most recent study, which Jenny will tell you about at the end. And noted that a lack of assertiveness on the part of parents leads to frustration and perhaps avoidable poor pain management. So once we had covered all of these areas, we brought the whole thing together. Sorry, I should say the last angle, because of course we wanted to check about how realistic it was to do this and to create this framework. And when we asked, we were told the main challenges to implementation were identified as the need for making pain management as important as safety. So that's quite a thing to say. Another suggestion was a shift in the culture, mindset, and working practices, all of which could help raise expectations about pain management. And a consultant said, changing the culture, that if you work in a culture where nobody feels it is acceptable for a child to be, a young person to be in pain. And mandatory pain education was deemed important, focusing on models of care, the communication, speaking to the family, the explanation about things, the documentation. So once we finished this study, we pulled the whole thing together and came up with this framework. And this has been published in 2020. And so these are the four key elements: is creating knowledgeable and confident practitioners, excuse me, supporting staff with relevant practice guidance, adopting an individual approach to child and family, and empowering parents to be effectively involved. So I'm going to move on now to a very short animation which pulls this whole thing together. And now this is where fingers and toes crossed for the video to play.
When children are in hospital, managing any pain they experience is essential, but it's not always done effectively. Many parents leaving hospital report that their child experienced a lot of pain during their stay, but they also feel positive about the care they received, which means something isn't working. Following extensive research with pain specialists across the UK and internationally, we've developed a framework for delivering effective pain management for children. There are 4 components. The first is creating knowledgeable, confident practitioners. Many nurses can feel nervous about giving too much pain medicine, and when nurses are not feeling confident, they may administer less than what's been prescribed to be on the safe side. The second element is the support given to those staff. Making sure they have access to relevant protocols ensures that they rely less on their own judgment and more on proven best practice. Pain protocols with well-evidenced guidelines for predictable scenarios are usually created by dedicated teams after a lot of hard work. But when the whole hospital implements them, they are shown to make effective pain management easier to achieve. Thirdly, nurses need to involve parents and treat them as partners. After all, they have unique expertise when it comes to their child. But parents are often reluctant to point out that their child's pain is not going away, so they need to be encouraged to speak up. Practitioners want to help, but if they don't know a child is in pain, they can't do anything about it. Lastly, it's important to take an individual approach to both the child and their family. Talking and listening to each child and finding out about their experience, understanding fears, likes and dislikes, makes it more likely that their pain can be managed effectively. To be effective, all 4 components need to happen with everyone at all levels playing their part. If all practitioners start using this framework together, it can contribute to managing children's pain a lot more effectively.
Okay, so I'm going to move on. I hope I'm going to move on.
When children are in hospital.
Let me see, page 10. Yes. Okay, so I probably went a little bit too far. Yeah, so that was the animation, and out of that study as well, we created 2 leaflets, one for parents and one quite a condensed leaflet, which we called a 6-minute briefing, to try and capture the whole thing in a very quick way, because we're trying to convey the messages of our findings, but it's actually, we know people are busy, far too busy, and it needs to be short and snappy. So this parent leaflet first, it was devised to distribute among parents. And if I show you, so it just says how you can help your child. It gives some information about children in hospital, ask the parents if they want to complete what the child would be like normally. And then this area here, I've just blown up on the next slide, because we know the parents find it difficult to approach a busy nurse. And we were saying, here are some things you might want to say when you talk to the doctors and nurses about your child's pain. I don't think the pain medicine is working properly. I think my child's still uncomfortable. I don't know why they're getting pain. I want to help my child cope, but don't know how. And I don't understand the medicine, how the medicine is supposed to work. So that's one leaflet. And the second one is this 6-minute briefing. And I've done this back to front, forgive me here. So it explains why pain matters, the background to developing the framework, why the need for a framework for pain management, implementing change, sharing information. I've done it wrong, haven't I? How can the framework bring about change, sharing information, and implementing change? So out of that study, which Wellchild funded, we had 1 short animation and 2 leaflets. So if I move on, and Jenny, I'm going to hand over to you.
Thank you, Joan.
When you want to move the slide on.
I will do. So our next study was focused on the part of the framework which was about empowering parents to be effectively involved. So in this study, we sought views from parents on how parents can be more involved in the management of their child's pain in hospital. So we recruited parents at the end of their child's inpatient stay, so we knew they could draw on recent experiences of having a child in hospital, usually post-operatively, so pain was a feature of that stay. And in the interviews, we used practice-based vignettes, so we didn't just directly ask the parent their experiences, it was for them to draw on their experiences based on different scenarios. And as you can see on the right-hand side, there were prompt questions talking about empowering, thinking about what the nurse or the parent or carer could do differently. Next slide, please. So the results of this study were that parents described to us what it felt like to witness their child in pain. They felt helpless, intimidated, nervous, worried, not in control, anxious, guilty. My nerves are shot. You feel like you're letting down your child if they're in pain. I feel hopeless. Parents suggested to us they needed to be mentally prepared as a parent before coming into hospital with their child. But you are the parent, you do feel responsible for your child's pain. Next slide, please. So the animation that was developed from this study addressed three key interlinked issues that parents raised. These were the importance of open and clear communication between parents and nurses, the need for parents to build a relationship with nurses so that they could feel confident to get help when their child was in pain, and the need to provide parents with information about their child's pain management so they felt empowered. Next slide, please. So this is the resulting animation.
Many children will need to stay in hospital at some point in their lives. For most, the experience won't have a lasting impact. But for some, it can be an anxious time. One reason for this can be unrelieved pain. We're working with parents, doctors, and nurses to improve this. When a child in hospital has pain, a few things usually need to happen for it to be managed effectively. The child needs to tell someone they have pain. That could be their nurse or doctor, parent or carer. If the nurse or doctor isn't aware of the child's pain, the parent may need to tell them about it. Sometimes parents don't feel comfortable asking a nurse or doctor for pain medication. Parents told us that in this situation they feel nervous or worried about asking for help. They worried about seeming too demanding, and some said you need to be confident to approach the nurses and doctors. Others said they felt lost in hospital and worried they would look foolish if they didn't understand their child's treatment. And when their child was in pain, they hesitated to bother nurses and doctors as they are so busy. But we also spoke to parents who approached the nurse or doctor caring for their child and received the help they needed to manage their pain. These parents described being told by nurses and doctors, "You can't bother us too much." And, "If you need anything, just come and get us." This meant they could approach the nurse or doctor, who then helped with their child's pain. We also spoke to nurses and doctors about encouraging parents to ask for help. They told us they want to work with parents to manage their child's pain. If they haven't picked up on it, they want parents to tell them. They said parents know their own child best and how they deal with pain. If you are in hospital with your child and they are in pain, remember the nurse or doctor wants to make your child comfortable. They need to know about it so they can help. If you're not sure what to say to the nurse or doctor, you could start with some of the following. "I don't think my child's pain medicine is working properly. I think my child is still uncomfortable. I don't know why they are getting pain. I want to help my child to cope, but don't know how. I don't understand how the medicine is supposed to work." By working together, nurses, doctors, and parents can reduce the number of children who experience pain during a hospital stay.
Next slide, please, Joan. Then our most recent study was funded by the General Nursing Council Trust. And in this study, we wanted to focus on issues associated with parents, young people and nurses' experiences of working with one another. And we use cognitive interviews, which are designed to allow the participants to give you an honest response rather than an ideal response or the response you might want to hear from them. And there's a technique called think aloud. So think aloud means the interviewee is hopefully just telling you their experiences and their thoughts of their experiences. And then as the interviewer, you stay quite neutral or stony-faced. You're not trying to guide them at all. So that you're not encouraging responses in a particular direction. And this sort of interviewing then maybe allows cognitive errors to be manifest, and that was of interest to us. Next slide, please. So we interviewed 11 nurses, 8 parents, this time they were all mothers, and 4 children or young people. Again, this was practice-based scenarios. We'd recruited the parents, again, at the end of their inpatient stay. So again, they were drawing on their experiences, but based around set scenarios rather than individualizing it. Next slide, please. So this is one of the vignettes we used in this study about a 4-year-old who's had surgery, come back from surgery seemingly okay. And the nurses explained that Chloe's had pain medicine that's going to last the whole day, but then later Chloe's now crying and in pain, and her mum's worried that the pain medicine isn't working. And she's concerned that the pain must be bad, but she doesn't want to bother the nurses about asking for help. So then you can see we use this think aloud idea of what do we think the parent might do, what do we think the parent's thinking, and to the nurses, obviously, what did they think the nurse was thinking, what might the nurse do, what can be done about this situation. Next slide, please. So the nurses made a number of suggestions about ways to communicate key information to parents, such as posters, to provide more information, help parents feel more confident. Nurses were also aware that colleagues may make some comments to parents that were unhelpful, such as, well, there's nothing we can give him. There's nothing left to give, sorry. And nurses felt that was quite a defeatist and negative response, because there are numerous drugs we can give. There's always something we can do. Next slide, please. And then thinking about the things that get in the way of parents being involved in helping to reduce their child's pain, the busyness of the nurse. Parents felt acted as a deterrent to them approaching the nurse, even when the child was in pain. You can see how busy nurses are, and you think of all the other children that they're trying to look after. So it's just that uncomfortableness of going up asking for help, because you're in that environment, you're in the hospital environment, and they're the experts at the end of the day. It wouldn't be my first port of call to go to the nurse, because I know they're busy. But I'd have to do it. You feel like you're bothering them. Your child is in pain, and you do feel like you're bothering them. Next slide. So there was that idea of the overstretched nurse. But then parents expected the nurses to ask about their child's pain. But if nurses are busy and the parent doesn't ask about pain relief, then the nurse, the busy nurse, can mistakenly assume that the child doesn't have pain. Nobody's mentioned anything. And then parents also talked about the non-verbal cues that a busy nurse may display and how they acted as a powerful deterrent. You can tell when a nurse is overstretched. She doesn't smile. She becomes unapproachable. She just wants to come in, give the medication and be out again. She doesn't want to chit-chat. She's almost constantly chasing her tail or trying to catch up. And if I notice that that's what's happening, it makes me more reluctant to ask for what my young person may need. Next slide, please. So nurses said they recognised it's not always easy for parents to approach a nurse, but it's a shame that when the ward gets busy, nurses will rely on parents coming to tell them to raise the issue that the child's in pain, because the nurses may not notice. But nurses agreed that when a parent isn't confident, that they're going to hesitate or delay getting the help that they need from a nurse. But then obviously if parents have to wait a long time without managing to get help for their child, they're going to become more and more anxious, and this can ultimately lead to quite a tense encounter with the nurse. So in this time of waiting, hoping the nurse might turn up, the parents explained what they would try and do. They try and soothe their child. They try distraction techniques, engage them in some sort of small play to try and see if that's enough to distract them. Next slide, please. Parents are different, nurses are different, and obviously that was a feature of our study. Nurses said that parents react in different ways to their experiences of being in hospital with their child. Some parents just don't want to speak. Some parents don't want to bother us. Some parents on the other side want to shout at us. So sometimes it's really difficult with our jobs, just sitting and having 5 minutes with the parents. But having those 5 minutes with the parent can really help the situation. Nurses also said that different nurses provide care in different ways. This was put down to the nurse's individual practice and personality. They said, I do generally think it's just nurse specific how they approach situations. I know that all nurses know what they should be doing, but some people don't necessarily say the same things or say it in the same way. Next slide, please. So I love this quote. I generally think it's a lack of communication culture, whether it means it's a lack of communication culture or if it's a lack of communication culture. Either way, they're sort of as bad as each other. It's all down to communication. And parents experience different levels of engagement and care depending on which nurse was looking after their child. So then when we looked at the cognitive errors specifically in these interviews, it was pretty clear that when nurses are busy, they expect parents to find them, to alert them to the child's pain. But on the other hand, when parents see that the nurse is busy, it's a deterrent to them approaching the nurse. So that's a sort of perfect storm of a cognitive error. Nurses find it quite frustrating, the parents' reluctance, because we're busy and we expect parents to tell us if there are any issues. But it's not their problem that we're busy. We'll always make time for stuff, or we can delegate some stuff so we can make more time. I feel bad for them that they feel like we're too busy to spend time with them. That's often not the case. And obviously nurses told us that they don't want any child to be in pain and expressed frustration that parents were reluctant to interrupt them when their child needed help for pain. Nurses emphasised that parents should approach any nurse for help, but parents particularly wanted to speak to their child's particular nurse. And then the other cognitive error was parents expect nurses to ask about their child's pain, but if nurses are busy and the parent doesn't ask about pain relief, then the nurse will think, well, that's not an issue for them. The child hasn't got pain. So there's lots of assumptions there. And also you might just ask a quick, everything okay? And we're all well brought up. So we say, yes, thank you. And that isn't a formal pain assessment. and the parents left frustrated thinking, no, I didn't mean to say that. I meant to say, please, can we have some help? So that sort of language just isn't giving parents opportunity to raise their concerns. So as a result of a parent not approaching a nurse when their child's in pain, the pain can escalate. And then by the time the parent does approach the nurse, they're tense, anxious, frustrated about having to wait. While the child's pain gets worse, they're all very unfortunate. And the nurse has been busy elsewhere, so won't be aware of this build-up. Next slide. This is the final animation we're going to show you, and then I shall pass you back to Joan.
When a child is in pain, the relationship between parents and nurses is really important. We're working with nurses, parents, children and young people to understand how we can better manage children's pain in hospital. Some parents told us they are reluctant to bother a busy nurse, which can lead to lots of waiting. If a parent is unable to get help and their child's pain escalates, it can leave them feeling helpless and like they are letting them down. Parents say that waiting for a nurse is stressful, and they try different ways to help their child. Nurses empathise with parents and want to help. They tell parents, it doesn't matter if we're busy. Come and find us. Just grab us. But despite these messages, parents assume nurses are busy elsewhere and remain concerned about adding to their workload. Getting a child pain relief is always top priority for a parent, but nurses are juggling multiple care priorities. Nurses told us they never want to leave a child in pain. But if they don't know, other things that need recording, like fluid balance, can be given higher priority. Pain is invisible, and some nurses told us that they used their own judgment, and if a child looked okay, they didn't ask them about their pain. A child in pain, a busy nurse, and an anxious parent can lead to frustration, misunderstanding, and terse exchanges. So how can we communicate better to minimise this? Nurses and parents said that feeling confident and empowered were key. For nurses, this confidence allows them to be flexible and use different strategies to help with a child's pain. Parents told us these things gave them confidence. Being reminded to seek help from a nurse. Nurses listening to them and their child and showing they understood. The use of pain scores. Having information about pain relief medication and pain relieving strategies. Nurses can support parents to feel empowered by keeping these questions in mind. Does the parent know what to expect regarding pain? Does the parent know when to expect analgesia next? Has the nurse introduced themselves to the parent and child or young person? Does the parent know where to find a nurse when they need one? By working together and communicating better, we can reduce the number of children who experience pain in hospital.
So that's the end of our third animation. And thank you, Jenny. I'll just go to this last slide. So there are 4 studies that we've done. As you can see, we've got to a point now where we need to ideally get funding and test out, do the work, does it make a difference? You know, what's it all mean? And we are also going to be writing, we have drafted and it's about to be developed, an OpenLearn course. So at the Open University, we have, I think, hundreds, maybe thousands of free courses that go on our OpenLearn forum. And this is one of them, promoting it. So this is the course that was written in relation to the framework we talked to you about at the beginning. And then we'll do a second one in relation to that cognitive interviewing study. So that's all we have to present to you. It'd be great if you had, if we could open up the discussion, and if you want to let us know if you've got any questions, which we'll try to answer. So should I stop sharing my screen?
Sure, that's a good idea.
Great. Thank you.
Perhaps I could pose a question to you both, Joan and Jennie.
Thanks, Jo.
So we found that nurses were inconsistent in their practice, with comments on individual personality determining practice. Is this a problem? And if so, what can we do to avoid it?
Jennie, do you want to start? You're on mute.
You're on mute, Jennie.
Can you ask the question again? Sorry.
Sure, of course. So we found that nurses were inconsistent in their practice, with comments on individual personality determining the practice. Is it a problem? And if so, what can we do to avoid it?
That is absolutely the challenge. So as a pain nurse, I spend my life reviewing patients in pain, but also writing guidelines and teaching nurses. Nurses are all different. People are all different. Parents are all different. So how can you make sure that different personalities provide a consistent message, I guess, is the key. And I'm not clever enough to know what the answer to that is, apart from having a guideline so they all do a similar thing, but the way they go about it probably is the challenge.
And if I could add to that, I would say, as Jennie, part of Jennie's role is putting on education courses right throughout the year for nurses. And so the same standards, explanation, ways and approaches are shared and understood, but still people go away and think, oh, well, I just do it this way because that's the way I learned. And, you know, and we did have some nurses who were qualified a long, long time saying, well, I've always done it like this. And so there's a frustration there, because you will get other nurses saying, that's ridiculous. Why would anybody do that? You shouldn't do that. And there's that element of just this complex, knotty problem of everybody doing what they think is the right thing, but they're so inconsistent that the parents are saying, I don't know whether, you know, one day it's one thing, one day it's another, and the nurses themselves getting frustrated with each other. So the obvious thing is that it's down to education, but I think it's more than that, because where's the benchmark for pain management? Where's the a tiny example that you might have picked up in one of the videos was that nurses will always fill out the fluid balance chart, because that is something that's auditable. So we know that if somebody comes around and audits and there's 3 charts where nobody has bothered for the last 24 hours to record what a child has drunk or weed or pooed or whatever, then that's a problem. But if the same, you know, group of auditors checked for pain management and there's no pain management chart, or there's a chart with no records, it's not a problem because it's not audited. So as you can imagine, we're a little bit frustrated by that.
I can understand that must be a big challenge if it's not ingrained in your day-to-day job. And also there's no moment of reflection there either to reflect on if things are improving. You don't have that chance if it's not part of it. That's a great answer. I have just a general question here. Can we use and share the open access learning module within the trust? That's a question from April.
Yes, absolutely. And it is a standalone course. And what it does is it covers sort of the first half of our presentation today. And as I said, I'm doing another one, should probably be ready by the autumn, which will cover the second half. And the whole idea is that please use them, please disseminate the findings, please make whatever use you can of them. Yeah.
That's great, Joan and Jenny. Thanks for that. That will be really useful. I have another question then. So there was at times a bit of an us against them sentiment in the nurse interviews, and maybe some group thought, some group thinking, such as this is how we do it. You touched on this a moment ago, Joan, which kind of goes against this idea of notion of individualized care. So how realistic is it that we can expect that individualized care in relation to the management of pain? Is it realistic at all?
Shall I start, Jenny?
Yep.
One of the things that we heard right throughout the study was the busyness of the nurses, and then on the back of that, the reluctance of parents to bother a busy nurse. And the reason I put up the slide at the very beginning of the study I did 25 years ago was because it was exactly the same problem. Nurses are too busy, didn't want to bother them. And so individualized care, we know, is part of good practice. But at the same time, the reality is nurses are busy. They're busy every day. And the chances of them going into an individual child and parent in a cubicle and thinking, right, so what's different in here? This child has had this particular procedure, so I need to think differently. It's very easy just to think, every child who has this gets this. What's wrong with them? If they're still in pain, I don't know what else to do. And so I think the pressure nurses are under at the moment, just the sheer volume of their work means that individualized care is not really very realistic. And I think because one of the things Jenny described was, rather than asking, this is why we used cognitive interviews. So we didn't want to ask, what would you do if this happened? Because then traditionally somebody was, if you said to me, how many calories do you eat in a day? I would tell you on my best, skinniest day, how many calories I eat. But I wouldn't say probably 4,000 at the weekend. But so in an interview situation, you give the best answer. And we didn't want that. We wanted what happens in reality. And we know that in reality, nurses are busy and parents don't ask them. And so the idea of individualized care is an ideal rather than the reality a lot of the time. Jenny, did you want to come in?
And I guess it's the time taken to individualize that care. It requires a relationship, and lots of hospital processes are aimed at being more and more efficient all the time. So at the start of my nursing career, patients would be admitted to the ward I was working on the day before surgery. So that's all time that they're not in pain, they haven't had surgery, you get to know the child and family. These days, the children and their parents come through a different portal. So your first meeting of them is in the recovery room. So that's straight after surgery. And that's at the point you start making a relationship with them. But that's a busy time, end of surgery. That's not the only child that's coming back to your ward. You have to get them back to the ward, which takes time. You have to settle them in, sort out all the fluids, get the paperwork or the computer work sorted, deal with any immediate issues, and then go and get the next child. So there is no time to make a relationship. So it is very difficult to then personalize care. I see in the comments, Jessica has asked about whether neurodivergence in either parents or children comes up, and obviously a significant proportion of both children and parents are neurodivergent. It's interesting. It adds to the mix, but also neurotypical people are varied enough that you have to try and personalize your approach to them. In terms of neurodivergent children, though, it depends what their focus is on. And if their focus is not on pain because something more important or more challenging is happening, whether it's the noise of the environment or just the environment isn't their home environment, then it just means pain is not at the front of their mind. It's back here because something far more important is keeping their focus. So in post-op terms, post-op pain terms, neurodivergence isn't a challenge for us, a challenge for the children. The hospitalisation is the challenge for the children.
And we did a study a few years back, Jenny, if you can relate to the cognitive impairment study we did. What we found there was that those parents, those children, were left more than children who could actually answer and tell you what's wrong with them. And so nurses tended to leave those parents and children to their own devices, expecting mum again to come and tell you if there's a problem. But and these mums found that that was actually quite frustrating, because they could easily read their child, not surprising, but the nurses, again, not surprising, couldn't read the pain cues that a child was given off. So we found in those scenarios there was really considerable frustration, because they were given a wide berth by nurses, knowing that it was a complex situation and mum was the only one who could tell them, but then that flip side of the contradiction of expecting the mum to tell them. Yeah.
Excellent. Are there any more questions from anyone? Or is there anything else, Joan or Jenny, that you would like to just re-emphasise in the last moments of the webinar?
Well, I'd just love to say thank you, because this is the first time that we've brought all of these studies together and presented them. So it's been a fabulous opportunity to share them with like-minded people. I hope you've gained something from it. As said, we can share with Joe or Kate, who would have been here this evening. Unfortunately, she's not well. And when we have the OpenLearn course, we can share with you as well. And of course, as you said at the beginning, Joe, maybe we should be thinking about coming to the British Pain Society conference next year as well. So thank you so much. Jenny, did you want to say anything?
Only that it feels slightly like washing your dirty linen in public, because Joan at the beginning of the presentation talked about coming to Alder Hey because it was a centre of nursing excellence. And lo and behold, all the parents we recruited in these more recent studies are parents that have been in Alder Hey. And we're a hardworking pain team who are trying our best to put everything in place to optimise pain management. And yet these are the findings. So can't retire yet, because there's clearly stuff still to be done.
Lots of work to do, Jenny.
Yeah. But thanks for your time, everyone.
Thank you very much. And thank you.
Thank you so much, Joan and Jenny. That was such a fascinating presentation. I learned a lot, and thank you everyone for attending. We do appreciate it, and we hope you have a wonderful evening ahead. Take care, everyone.
Thank you so much. Thank you, everyone. Bye. Bye.
Bye.